Symposium Neglected Tropical Diseases is being organized by Tropical Medicine Subcommittee of Clinical Infectious Disease Society India and Manipal Center for Infectious Diseases. I, Dr. Kavita Sarao, Professor and Head of Department of Infectious Diseases at Kasturba Medical College, Manipal, is very pleased to have Dr. Shyam Sundar, Professor of Medicine, Department of Medicine at Benares Hindu University as a co-moderator. It's my proud privilege to request Dr. Shyam Sundar to give an overview of Neglected Tropical Diseases Day. Over to you, sir.
Thank you, Kavita, for inviting me. It's really a pleasure to be here and to be joining this symposium. Actually, neglected tropical diseases, or they are also called as NTDs, are a diverse group of 20 conditions that are mainly prevalent in tropical areas, and they affect mostly the poor communities. These diseases cause devastating health, social, and economic consequences to a large proportion of global population. The epidemiology of NTDs is complex and often related to environmental conditions. Many of them are vector-borne, have animal reservoirs, and are associated with complex life cycles. All these factors make their public health control challenging. NTDs have historically been ranked very low and almost absent from the global health policy agenda till before 2015, when they got little recognition, and it was included in the SDGs, Sustainable Development Goals of the, and it can only be achieved. The SDG can only be achieved if the NTD goals are met. The 1090 gap challenge states that the disease and health problem that constitute roughly 10% of the global disease burden, 10% of global disease burden, mostly affecting people in rich countries, receive 90% of the overall health research attention and funding. This is a sorry state of affairs. The things are changing a little bit for NTDs for the last 7 to 8 years, and they are getting more attention as compared to previous, and that is why the name is neglected. For in India, I think dengue, leishmania, leprosy, soil-transmitted helminths, snake bite, and other diseases also, they form the major part of the NTDs. And they actually, if you can understand that there has been hardly any advancement or any new drug coming to for these diseases. It is mostly the it is discovered. I mean, the whatever drugs have been there, they have been invented for some other diseases, and they have been applied to these tropical diseases. And I think there is a greater attention which needs, and some of them have got. I must say that, I mean, diseases like leishmania in our country has got a lot of attention, with the result that almost we are at the verge of eliminating this disease from India. So we need the similar attitude for other diseases as well. Leprosy is a neglected disease, and it still occurs in 120 countries, and more than 10,000 cases, new cases, are reported from India every year. And I think this is a gross underreporting. So it is very important to discuss leprosy in this fora. Similarly, soil-transmitted helminths are the most common infections worldwide. And in India, around 241 million children between age of 1 to 14 are at the risk of parasitic intestinal worm infestation. So it is very apt that we discuss these conditions, and I am very happy to know that we are bringing these entities to attention of the various people and I really wish this symposium a great success. I'm sure it will be. Thank you, Kavita.
Thank you, sir, for that overview of the neglected tropical diseases and about today's lectures. So the first lecture is going to be by Dr. Raghavendra Rao on leprosy. Leprosy, which is also known as Hansen's disease, and which is named after a Norwegian physician, Gerhard Hansen, for the discovery that he made about the causative organism Mycobacterium leprae of leprosy, and also invented the diagnostic test for leprosy. All the physicians, dermatologists need to be familiar with manifestations, presentations of leprosy, and they need to have high index of suspicion to diagnose. So that's why leprosy, which is known as a great masquerader, we have requested Dr. Raghavendra Rao, a renowned dermatologist who is a professor and head of Department of Dermatology at Kasturba Medical College, Manipal, to speak on this very important topic. He has many awards and honors. He is a Commonwealth Academic Fellow at St. John's Institute of Dermatology, St. Thomas Hospital, London. He has been awarded the B.N. Banerjee Award for the best paper presented in Dermacon, and Dr. Bhanupriya Devi Award for best paper published in Indian Journal of Dermatology on 2 consecutive years. Professor J.M. Shitty Oration, best PG dissertation presented at Dermacon 2019 and 2022. He is also editor-in-chief of Indian Journal of Dermatopath Diagnostic Dermatology. The very accomplished dermatologist, and I'm very happy that he'll be addressing this symposium. Over to you, Dr. Raghavendra.
Thank you, Dr. Kavita. Thank you, Dr. Kavita, for the wonderful introduction. Today we are celebrating the World Leprosy Day, and this talk is more relevant in that aspect because we are reviewing some of the aspect of leprosy, which even though was considered as eliminated from our country or throughout the world, we still get to see a lot of cases, mostly with the atypical manifestation. So that is why this talk is very relevant today. So today I'll be talking about leprosy and I'll be touching about some of these aspects. I'll be giving a brief introduction of leprosy, followed by classification of leprosy, briefly telling you about the clinical manifestations, and most important, or the core of today's presentation, is case-based discussions. Some of the atypical manifestations of leprosy which we happen to see over the years. So leprosy, or Hansen's disease, as Dr. Kavita rightly pointed out, is one of the oldest infection known to mankind. It's a chronic mycobacterial disease caused by Mycobacterium leprae or genetically related Mycobacterium rhabdomatosis. It primarily affects peripheral nerves. Secondarily, it can involve skin, mucous membrane, and various other internal organs. It is considered to be a dermatological disease because most of the time patients manifest with skin lesions for the first time. So, Government of India and even the WHO has announced that leprosy has been eliminated in the year 2005 as a public health problem. But unfortunately, we have been seeing a lot of increases, lot of cases of leprosy, even among children. And we also happen to see a lot of children with deformities, which indicate that leprosy is still prevalent in the community, in certain pockets of the community. So that is why we need to know about this disease very well. So how do we classify leprosy? Leprosy can be classified, the most relevant or the important classification system that is practiced nowadays is called Riley-Joplin classification. So according to this classification, this classification is based on 3 aspects. One is based on the immunity of the patient. Second is based on the bacteriological index of the patient. And the third is based on the histopathological aspect of the affected patient. So there are 2 polar forms of leprosy according to this. One is called tuberculoid or TT leprosy. And the other polar spectrum is called lepromatous leprosy. In between these two pores, we have borderline leprosy, which is otherwise known as dimorphous leprosy or unstable leprosy, because the cell-mediated immunity in these patients is very unstable, and these patients can shift in either direction, either towards tubercular pole or towards lepromatous pole. So borderline leprosy is again subcategorized into borderline tubercular leprosy, mid borderline leprosy, or borderline
Excuse me, I
lepromatous
request
leprosy.
all the delegates to keep their microphones muted. Thank you.
So this is the most widely used classification in the clinical practice. But apart from that, we also use other classification systems, such as WHO classification system. According to this classification, leprosy is divided into paucibacillary leprosy and multibacillary leprosy. So this is more relevant from the treatment perspective, because paucibacillary, as the name suggests, means less number of bacilli, and we use 2 drugs to treat paucibacillary leprosy. So this classification is mostly given by WHO to the health workers in the field, so that they can just count the number of lesions in the affected patients and then classify them into paucibacillary or multibacillary. In paucibacillary leprosy, affected patients will have less than 5 lesions, whereas in case of multibacillary leprosy, they will have 5 or more lesions. So how do we treat these patients? So we use multibacillary, multi-drug therapy. In case of paucibacillary leprosy, we use only 2 drugs, dapsone, 100 milligrams, and rifampicin once in a month for 6 months. Whereas in case of multibacillary leprosy, in addition to these 2 drugs, we also use clofazimine, 300 milligrams once in a month and 50 milligrams daily. But because we are sitting in the tertiary care hospital, we often get to see patients who are highly bacillated. So for this highly bacilliferous patient, we often add one of the other bactericidal drugs, such as ofloxacin or moxifloxacin or minocycline. So these are the second-line treatment for leprosy, and we use them when the bacillary count is very high, in addition to the standard WHO recommendation. So what are the cardinal signs? How do we diagnose leprosy? So WHO has given us 3 cardinal signs, and presence of one sign is more than enough to make the diagnosis and start the patient on treatment. So the first cardinal sign is hypostatic hypopigmented patch. So there has to be a white hypopigmented patch, and over the patch, if you look for the sensations, there should be either loss of sensation or diminished sensation over the patch. The second, you can see here in these photographs, there are hypopigmented patches, and there's a small patch in the vicinity of big patch, and this small patch is called satellite lesion. So this indicates it's a borderline tubercular leprosy. The second cardinal sign is thickening of peripheral nerves. So you can see here there is very gross thickening of great auricular nerve, which is crossing the sternocleidomastoid muscle. So this is the thickening of this is the second criteria. So thickening should be affecting the larger peripheral nerve trunk, not the smaller ones, not the cutaneous nerves. And the third criteria is demonstration of acid-fast bacillus from the split skin smear specimens. So at least one sign should be there to make the clinical diagnosis of leprosy. So not all patients will present with hypopigmented patches. For example, this patient who came to us a few years back, and he had this coppery brown or coppery red patches, and this is his normal skin, and he had multiple coppery red or coppery brown patches. So just because there is no hypopigmented patch, you should not rule out Hansen's. You still can consider Hansen's, because some of them can present with diverse manifestation. So this is again an interesting case who was admitted in medicine department with a history with a clinical diagnosis of mixed edema, because he had generalized edema all over the body. So a patient, he was referred to us for the dry skin, and when we examined him, he had pitting edema, and he also had few nodular lesions on the ear lobules as well as on the dorsum of hands. We took smear, and smear was highly positive. So this patient is a patient of lepromatous leprosy, and lepromatous leprosy patients can present initially with bilateral pitting pedal edema or nasal stuffiness or sometimes hemoptysis. So these are considered to be the early manifestation of leptomatous leprosy, one should remember. So few words about reactions in leprosy. So what are reactions? Reactions are nothing but episodes of acute inflammation occurring in the course of chronic disease. So suddenly, if the patient in a normal course of leprosy, the lesions are there are no signs of acute inflammation. On the contrary, there is loss of sensation. Patient will not be able to appreciate the sensation. There is no pain at all. But if the lesion becomes more edematous, or if the patient develops sudden onset of pain, then you suspect lepra reaction. So what are the types of lepra reactions? We have two types of lepra reaction. Type 1 lepra reaction, which is classically seen in the borderline spectrum. As I told you in the beginning itself, it's a very immunologically unstable spectrum. So immunity can shift in either direction, and thereby predisposing them to develop type 1 lepra reaction. So it is otherwise known as reversal reaction or upgrading reaction. The second type of reaction is called type 2 lepra reaction. One of the most striking manifestation of type 2 lepra reaction is erythema nodosum leprosum. So here you can see in the first two pictures, you can see multiple large erythematous lesions on the face as well as on the ear lobules. So this patient probably had hypopigmented lesions which went unnoticed, and suddenly he developed edema and erythema for the lesions. So this is a classical example of type 1 lepra reaction. Type 1 lepra reaction, patient will not develop any new lesion usually. On the other hand, in type 2 lepra reaction is usually seen in leptomatous leprosy, sometimes in borderline leptomatous leprosy. So the existing lesions will remain as it is in case of type 2 lepra reaction, but patient will develop multiple erythematous, tender, and evanescent lesions. Evanescent means the lesion will come in crops. They will persist for 72 hours and then they disappear, and patient will develop fresh crop of lesions. So this is very classical manifestation of type 2 lepra reaction, erythema nodosum leprosum. Now, type 1 lepra reaction is an example of delayed type of hypersensitivity reaction, whereas type 2 lepra reaction is an example of immune complex mediated or type 3 Coombs and Gell classification. So type 2 lepra reaction will have a lot of constitutional disturbances. They might have iridocyclitis, they might have orchitis, they might have mild neuritis, and they might have arthritis. So patients with type 2 lepra reactions generally feel very sick. Whereas type 1 lepra reaction, when it is mild, it will affect only skin. When it is more severe, there will be very severe neuritis, and sometimes if it goes unrecognized or untreated, they can develop crippling deformities. So that is why you should recognize and treat type 1 lepra reaction as early as possible to prevent the crippling deformities. Now, coming to the most important agenda of today's talk, I'll be telling you some of the interesting cases that we came across over the years. So this case was admitted in surgery ward for the treatment of orbital cellulitis. So she was 23-year-old female, postpartum 4 months, and she was admitted in surgery for the management of orbital cellulitis. So she was treated with IV antibiotic for 1 week, and there was absolutely no change in this in the skin reaction or erythema or skin inflammation over the face. Then a consultation was given to us to be examined, and then we concluded that this is the borderline tubercular leprosy with type 1 lepra reaction. We started her on treatment with NBMDT and tapering doses of steroids. You can see here at 3 months interval, most of our skin lesions have subsided, have flattened out, and at the end of 6 months, it's almost clear. So sometimes it can be mistaken for other conditions. Borderline leprosy affecting the face can represent in different forms and can mimic many other conditions. The second case is again a 53-year-old man who presented to us with upper lip edema, or we call it as macrocylia. So there are many causes of macrocylia, which includes other granulomatous conditions such as sarcoidosis, tuberculosis. It could be because of leishmaniasis, or it could be some other conditions such as Merkel-Rosenthal syndrome or Mission cheilitis. And when we closely looked at the lesion, in addition to the upper lip edema, there is a little bit of erythema in the lower lip area. And then we took biopsy from this side, which confirmed the diagnosis of Hansen's disease. So this case was published in Leprosy Review some time back. So this is a case of borderline leprosy presenting as macrocylia or cheilitis granulomatosis. The third case is a 41-year-old farmer from interior Karnataka who had this kind of presentation. He had erythematous and scaly plaques affecting the extremities and trunk, and the lesions were seen on the extensor aspect of extremities. So he consulted a dermatologist at his place, and he was diagnosed as psoriasis, and he was started on methotrexate. So, but there was no improvement with the treatment. Then he came to us, we examined him thoroughly, and we concluded that this patient actually has borderline tubercular leprosy with type 1 lepra reaction. So type 1 lepra reaction can sometimes present with this type of scaly erythematous plaques. So we need to consider reaction leprosy, especially when somebody has psoriasiform lesions in an atypical distribution or atypical presentation. The fourth case is a 15-year-old girl who had asymptomatic skin nodules since the age of 10 years. And she also had pigmented lesions in infancy. You can see here the pigmented lesions. She had multiple these kind of lesions. But the reason for our visit to the hospital was sudden onset of new skin lesions. So we had multiple cafe spots. You can see here, this is one of the cafe spots. She had neurofibromatosis. She had multiple neurofibroma. But in addition to that, she also had this kind of nodular lesions on the extremities as well as on the ear lobules. So in addition to neurofibromatosis, this girl was suffering from lepromatous leprosy. So this makes it more challenging because both neurofibromatosis and lepromatous leprosy can present with nodular lesions. Both can present with hypopigmented lesions, though it is more common in leprosy compared to neurofibromatosis. But classically, neurofibromatosis will have multiple cafe-au-lait macules. A classical neurofibromatosis will present with multiple cartwheels and nodules, which is sitting on the skin. Whereas in case of lepromatous leprosy, you can see here, they are slightly infiltrated lesions. They are present deep inside the skin in the dermis. So that's how you make the diagnosis. So though uncommon, there are few reports of coexistence of lepromatous leprosy with neurofibromatosis. My next case is case 5, who is a 50-year-old female, and she presented to us with multiple pustules over the extremities, and as well as she had leg ulcers. So she was a known case of diabetes mellitus, and when we checked her sugars, it was very high. She had sugars in the range of 300 or 400 ppbs. So she had uncontrolled diabetes. So in this background of a patient who has uncontrolled diabetes mellitus, when they have pustules, it is quite natural for us to consider the possibility of secondary bacterial infection or pyodermas or furunculosis. But when we took the gram staining of these lesions, it was sterile, so there was no bacteria at all. Then when we delve deep into the history, she said that she was diagnosed with BL hands leprosy 11 months back. And because the treatment was started at her hometown, but then she was not compliant to treatment, because whenever she took treatment, she used to develop this kind of pustular or nodular lesions and severe body ache. So that's why they stopped treatment. So we took her smear, bacteriological index was 5 plus and morphological index was 1%. And the biopsy from the pustular lesion showed macrophages with foamy and Fight stain also was positive. So we made the diagnosis of pustular erythema nodosum leprosum with erythema necroticans, which is a variant of type 2 leprosy reactions. You can see here multiple large deep ulcers over the legs, as well as she had multiple pustular lesions over the extremities. So this is an unusual variant of type 2 leprosy reaction, where patient presents with pustular lesions as well as ulcerative or necrotic lesion. So she was also started on MDMDT with steroids and thalidomide, which is considered as the drug of choice for type 2 leprosy reaction. So this is the clinical photograph at another patient, old man who had pustular erythema nodosum leprosum. You can see there are multiple nodular lesions all over the body, and some of the nodules there are pustule formation. So this is another example of pustular erythema nodosum leprosum. So coming to the case number 6, and this is one of the cases that we came across recently. So she's a 31-year-old female who was a treated case of Hansen's disease, and she took 1 year of MMDT from April to March 2022. And then after stopping the treatment, she started developing multiple painful lesions over the body. And when we examined them, she had this kind of central crested lesion, which is surrounded by an erythematous halo. So when we see this kind of lesions, we call them as target lesions, or which is classically seen in erythema multiforme. So this is the typical target lesion, where you have a central hyperpigmented crusted lesion, which is surrounded by an erythematous ring. So this is again a type of erythema nodosum leprosum resembling erythema multiforme. So erythema multiforme like presentation of type 2 leprosy reaction. So we did that smear, and smear was positive, bacteriological index was positive, 4 plus, and morphological index is 0.1%. This is very interesting because she has already completed 1 year of MBMDT, and even then morphological index, which measures the live bacilli in the body, was still positive. So according to the literature, a single capsule of rifampicin is able to kill majority of acid-fast bacillus. So morphological index should become negative in patients who are taking the treatment regularly. But then in certain situations, it can still remain positive at the end of 12 months, either because of the persisters, or it could be because of drug resistance. In fact, there was a report, a late leprosy reaction presenting as erythema multiforme like ENL lesion in a patient who had rifampicin resistant. So this is something that we need to think about in a patient who has this history or this background history. So persistence of acid-fast bacillus as indicated by a positive morphological index, even after the completion of MBMDT, indicates either she has a persistence which became reactivated now, or because of the drug resistance. So at another patient who consulted us recently, he had multiple erythematous non-tender lesions all over the body, and in addition to that, he had generalized body ache, and then he also had inguinal lymphadenopathy. So he consulted doctor in his place, and he was treated with intermittent doses of steroids, with which the lesions used to improve, but again used to relapse after stopping the treatment. So again, we thought this is a case of Sweets syndrome. Sweets syndrome is a dermatological condition where which is otherwise known as acute febrile neutrophilic dermatosis, which is usually seen in the setting of many internal diseases, including leukemias, lymphomas, inflammatory bowel disease, or solid organ tumors, or sometimes it could be drug-induced, such as GM-CSF. So this is a case of erythema nodosum leprosum presenting as sweet syndrome. So we took his biopsy, we did smear, and smear was positive. Biopsy confirmed the diagnosis of Hansen's disease, and he was started on MBMDT with tapering doses of steroids because he had reaction with which he had complete resolution of his skin lesions. In fact, I happened to see him on Saturday, and he was doing extremely well. There are no lesions at all. So erythema nodosum leprosum can present as sweet syndrome. In fact, you can see here, this is published in sweet syndrome. The case of sweet syndrome was published in New England Journal of Medicine, and this is how a classical sweet syndrome presents, and this is the presentation in our patient. So case number 8 is yet another interesting case of 32-year-old teacher who had this painful digit, and he was admitted in orthopedics for the evaluation. And also, orthopedic surgeon observed that there are some skin lesions, and he was referred to us. So when we examined, we thought it could be Hansen's disease, and so in this case, it is in fact a Hansen's disease presenting as phenocyanamitis. So that is one of the rare presentation of leprosy. We should consider Hansen's disease and need to do a thorough examination and look for the presence of skin lesions. So we have done with some of the cases of leprosy which mimic other conditions. Now there are some other conditions which were originally thought to be leprosy, but then after further evaluation, we confirmed that they were not actually leprosy patients. So this man is a 42-year-old man who had this kind of erythematous nodular lesions all over the face, extremities, as well as he had earlobe infiltration. So it is quite natural that whenever somebody has this kind of presentation, we think about leprosy, and he was investigated outside. Smear was done, smear was negative, and biopsy showed epithelioid granuloma, and he was started on multibacillary multi-drug therapy for 12 months. So he took the treatment diligently for 12 months, but he did not observe any change at all in the skin lesions. So that is the time when he visited us. So we evaluated the patient, and almost simultaneously, we also happened to see another man who also had almost similar history. He's a retired bank employee, and he had this kind of very annular looking erythematous lesions on the forehead, on the occipital region, and there were few lesions on his right forearm. So he was also investigated, smear was negative, biopsy showed epithelioid granuloma, and these granulomas were specifically present around the nerves and around the appendageal structures of hair follicles, which is inconsistent with leprosy granuloma. So that is why you started on MBMDT for 18 months, but there was absolutely no improvement in the skin lesion. So we thought of some other diagnosis, and we got the X-ray done for the first patient, which showed hilar shadows, and the CT scan was done for the second patient, and that showed multiple hilar lymphadenopathy. AC levels were done, and it was high in both patients. And these cases were actually sarcoidosis, cutaneous sarcoidosis, misdiagnosed as masqueraded as leprosy cases. So this is something that we need to consider, because leprosy as well as sarcoidosis can present histopathologically with epithelioid cell granulomas. And sarcoidosis, though classically described, we get to see naked cell granuloma, which means that there are no lymphocytes around the infiltrate around the epithelial cells. Sometimes they can have an atypical presentation, and these granulomas can present discretely around the hair follicles, around the hair blood vessels, as well as around the dermal nerves. So that leads to the confusion whether it is leprosy or sarcoidosis. So this is my last case. Not all patients with some manifestations are leprosy. This is in fact referred to us from medicine department a few years back, in fact 1 decade back, and you can see clearly here referred to dermatologist for ruling out Hansen's disease in view of loss of eyebrows. So please remember that there are 101 causes of madarosis. Though leprosy is one of them, this is not leprosy. This is in fact a case of alopecia totalis, which is an autoimmune disease. He had no other signs of leprosy at all. So that completes the case scenarios where I discussed some of the interesting cases which mimicked leprosy or some of the atypical manifestations of leprosy. So to conclude, leprosy is still prevalent, and we need to consider the possibility of leprosy, especially when somebody has atypical manifestations, need to do smear and histopathological examination, and ultimately it is the clinical pathological correlation that is very important, and clinicians should examine these patients with open mind so that a correct diagnosis can be arrived at. So I would like to acknowledge the contribution of my colleague, Dr. Anusha, in sharing some of the cases. So thank you once again for the patient listening. If there is any question, I will be happy to answer. Thank you very much.
Thank you, Dr. Raghavendra, for that excellent overview of Hansen's disease atypical presentations. So we are just crossed the time limit. So I request you to answer the questions in the chat box. And if you could stay for till the end of the session, we could have some more questions from the participants. Thank you once again. I request Dr. Shyam Sundar to take over the proceedings.
Thanks, Kavita. Actually, now next 2 sessions are going to be on soil transmitted helminths. Before I go there, I must reiterate that today is also World NTD Day, 30th January. And I think I forgot to mention that. And we are trying to catch the attention of people. I mean, this is what it is meant for. And this symposium probably will also attract attention of the important people as well who really matter in as far as policies are concerned. These soil-treated helminthic infections affect the poorest with poor access to clean water, sanitation, and they are in need of treatment and preventive options. Intervention. Open field defecation plays an most important role in its transmission. And lately, there have been serious attempts to eliminate this huge social and economic problem. Health education reduces and reinfection by encouraging healthy behavior. Periodical treatment aims to reduce the infection. And it is thought that this can be done by integrating it to the existing health programs. So without going much in detail, I have a great pleasure in inviting Dr. Venkat Ramesh, who is consultant in infectious diseases, and he's present. He is affiliated to Apollo Hospital, Hyderabad, and he has some very excellent achievements like Certificate of Knowledge in Clinical Tropical Medicine and Travelers Health of American Society of Tropical Medicine and Hygiene. He is a diplomat of Royal College of Pathologists, a very coveted honor. His diploma in Tropical Medicine and Hygiene from Liverpool School of Tropical Medicine, again a very coveted qualification. He is a fellowship of he has become a fellow of infectious diseases of National Board, fellow of Royal Society of Public Health, and Global Health and Humanitarian Medicine course. He is he's published many papers and is basically interested in tropical medicine and parasitology. So I invite Dr. Venkat Ramesh to start his discourse.
Thank you, sir, for that very kind introduction. Very kind, very generous introduction. So we're running a little short of time, but I will try to complete my presentation in 20-25 minutes. So the topic that has been given to me is an overview of soil transmitted helminths. And what I want to take the audience to is that the soil transmitted helminths actually include 3 organisms: roundworm, whipworm, and hookworm. And traditionally, Strongyloides was not included in the definition because of the lower prevalence and lower associated morbidity. And also because albendazole is a common drug given for roundworm, hookworm, and whipworm, which does not work against Strongyloides. So it's not included in the Mass Drug Administration's program for soil transmitted helminths control. So that's something that the WHO has now reinforced since 2021. Ivermectin is available, and Strongyloides is included in the STH programs. So one thing to understand is that it's very difficult to eradicate these infections because some infections like tetanus can never be eradicated, and there are billions of microorganisms in a handful of soil. So as sir has mentioned, soil transmitted helminth infections, they really affect a large number of people worldwide, about 1.5 billion people, or 24% of the world's population. And these are basically people living in the least privileged societies in tropical countries. So poorest and most deprived communities with poor access to clean water, sanitation, and hygiene. And highest prevalence is reported from sub-Saharan Africa, China, South America, and Asia. So, and these are statistics. So that a significant number, millions of preschool age children, school age children, adolescent girls, and pregnant and lactating women are affected by the soil transmitted helminths. And the public health programs are basically targeting this particular population. Globally, over 600 million people are estimated to be infected by Strongyloides, but this parasite is transmitted in areas where sanitation is poor. Geographical distribution will overlap with the other soil transmitted helminths. So this is just a slide showing the global distribution of hookworm. And if you can see, some countries are much higher. 60% of the 5.2 million disability adjusted life years lost to soil transmitted helminths are attributable to hookworm, mainly due to hookworm anemia or iron deficiency anemia. And the geographical reach is constrained by the ecological requirement of a warm, moist soil for larval development, which is why don't really see it in North America and the Europe. Strongyloides is seen again in certain pockets worldwide, and perhaps even to some extent in Europe and North America, and even some countries like Australia. So overall, these helminthic infections or soil transmitted helminths are highly prevalent, often asymptomatic, and eosinophilia is related to tissue migration. So if you see the world prevalence of Ascaris, it is affecting more than 1 billion, Trichuris and hookworm more than 500 million, Strongyloides is approximately 100 million people. Okay, so this is what I had mentioned. The main species that infect people are roundworm, that is Ascaris lumbricoides, whipworm, that is Trichuris trichuria, and the hookworms, Necator americanus and Ankylostoma duodenale, the New World and Old Worm hookworms, respectively. Okay, so these essentially require similar diagnostic procedures. I'll just mention that basically what we look for is the egg of these organisms in the feces, and they respond to the same medicines, that is albendazole. Strongyloides, however, is an intestinal helminth with peculiar characteristics. For Strongyloides, you will need to detect in asymptomatic or uncomplicated Strongyloides, you will need to see the rapidly formed larvae in the stool, which is not really very sensitive method. Probably serology is more effective. Thus, it requires different diagnostic methods than the previously mentioned soil transmitted helminths and is frequently not identified. It is not sensitive to albendazole or mebendazole and is therefore not impacted by the large-scale preventive treatment campaigns targeting the other soil transmitted helminths. So the three soil transmitted helminths, that is hookworm, roundworm, and whipworm, the eggs are passed in the feces of infected people. So the adult worms live in the intestine and they produce thousands of eggs per day. In areas that lack adequate sanitation, these eggs contaminate the soil. And again, the cycle continues because they are, at least in cases of Ascaris and whipworm, they are ingested. So eggs are ingested in a couple of ways. They are attached to vegetables when vegetables are not carefully cooked, washed, or peeled, or contaminated water sources, or children who play in the soil, they may ingest these eggs. Hookworm, though, it's a little different. It is acquired percutaneously. That is, the hookworm eggs hatch in the soil. The larvae that mature then form into the form that penetrates the skin, and people become infected mainly by walking barefoot on contaminated soil. So for all of these, there is no direct person-to-person transmission because it requires about 3 weeks for the eggs which are passed in the feces to mature. Only Strongyloides multiplies in the host. The others, Ascaris, Trichuris, and hookworms, do not multiply. Reinfection occurs only as a result of contact with infective stages in the environment. Strongyloides, very important point to remember, is that in immunocompromised hosts, its uncontrolled multiplication can be fatal. So that is something to remember. And I'll just very quickly run through the diagrams. So here, as you see, the for Ascaris, you have a unfertilized and fertilized egg. The unfertilized egg does not undergo further development, and the embryonated egg with L3 larvae is then ingested. The larvae are coughed up and swallowed, re-entering the gastrointestinal tract, and maturation proceeds in the small intestine. And the diagnostic stage really is the demonstration of the eggs in the feces. Okay, so for the hookworm, actually, again, you have the hookworm egg in the feces. The rapidly formed larvae hatches, it develops into filariform larvae, which penetrates the skin, and the larvae exit the circulation in the lungs. They are coughed up and then swallowed. So there are small differences between ankylostoma and necator. The ankylostoma larvae can become developmentally arrested and dormant in tissues. Reactivated larvae may then enter the small intestine, and ankylostoma may also be transmitted by ingestion of the larval forms, but predominantly it is percutaneous. So this is actually a beautiful picture of a hookworm egg, which is about 60 to 75 microns into 35 to 40 microns. So Trichuris, a very simple life cycle. Unembryonated eggs are passed in the feces, which is the diagnostic stage, and then it undergoes cleavage. Embryonated eggs are ingested, and they hatch in the small intestine. Adults are mainly seen in the cecum and colon. For Strongyloides, it is a little complicated, but just remember the rapidly formed larvae are in the intestine, are excreted in stool in the uncomplicated cases. They can directly or indirectly develop into filariform larvae, which penetrate the intact skin of the definitive host, which is man. The filariform larvae migrate by various pathways to the small intestine where they become adults. And here you have the larvae developing into parasitic adult females, which then deposit the egg in the intestinal mucosa. So this rapidly formed larvae, which emerges from the egg, can become filariform, penetrate the intestinal mucosa or the perineal skin, and migrate to other organs. So this cycle is known as autoinfection and leads to massive multiplication of a large number of organisms in the host, and is predominantly seen in immunocompromised hosts, basically patients with severe degree of immunosuppression. So how do these soil transmitted helminths affect the nutritional status of the host? So basically, they feed on the host tissues, including blood, which can lead to a loss of iron and protein. Hookworms can cause chronic blood loss, resulting in anemia, especially in adolescent girls and women of reproductive age, where the demands are quite high. So for hookworm, please remember that it is three things that lead to the hookworm anemia. One is, of course, the degree of worm burden. The second is the iron demand, and third is iron intake or ingestion. So adolescent girls, women of reproductive age, they are quite seriously affected. It can also cause malabsorption of nutrients. Roundworm may possibly compete for vitamin A in the intestine. A lot of these infections can cause anorexia, loss of appetite, and therefore reduction in nutrition intake and physical fitness. And trichuris can cause diarrhea and dysentery. So here you can see the hookworms, which are 1 centimeters long, are attached to the walls of the jejunum by the buccal capsule. This is a manifestation of hookworm anemia. So just remember that in the soil transmitted helminths, the morbidity is predominantly related to the worms harbored. That is, if you have heavy worm burden, that will result in multiple symptoms, intestinal manifestations, malnutrition, general malaise, weakness, impaired growth, and physical development. And predominantly in case of Ascaris, very high intensity can cause intestinal obstruction. The Ascaris roundworm can migrate to various locations. It can cause cholecystitis, cholangitis, pancreatitis, intrahepatic abscesses rarely. Can also cause volvulus intussusception, intestinal obstruction if it is pretty large. Strongyloides may cause dermatological and gastrointestinal morbidity, is known to be associated with chronic malnutrition in children. And as I mentioned previously, in cases of reduced host immunity, the parasite can cause hyperinfection or dissemination that is invariably fatal if not promptly and properly cured, and is often fatal despite the treatment. I think a lot of ID physicians or physicians in general would have had patients with disseminated strongies, and invariably it's a devastating condition. And despite multiple doses of ivermectin, they don't do well. Okay, so see, in strongyloides, you have a characteristic rash called as larva currens, which proceeds at a rate of about 2 to 10 centimeters per hour. So it is a very quickly migrating rash. And this occurs on the trunk, buttocks, or thighs. And this has to be differentiated from the cutaneous larva migrans. Hemorrhagic pneumonia in strongyloides infection, you can see a bilateral confluent interstitial and alveolar infiltration. And usually in these patients with disseminated strongyloides, the filariform larva can be seen in the bronchoalveolar aorta, sputum, body fluids, whereas in uncomplicated is the rhabditiform larva seen in the feces. So very quickly jump to the WHO strategy for control. So as I mentioned previously, the WHO really focuses on the population that is most impacted with the soil transmitted helminths. So they include preschool children, school-age children, and women of reproductive age, that is pregnant women in the second and third trimesters, and breastfeeding women, and certain adults in high-risk occupations such as tea pickers or miners. Okay. So what the WHO recommends is periodic medicinal treatment, which is also known as deworming or preventive chemotherapy, without a previous individual diagnosis, to all at-risk people living in endemic areas. So I think all these phrases are important. That is preventive chemotherapy or deworming or periodical medicinal treatment without a previous individual diagnosis. So we do not do the stool microscopy. It is done for all at-risk people and in living in endemic areas. So this reduces morbidity by reducing worm burden. Two other important points which have to be emphasized are health and hygiene education and provision of adequate sanitation. The other important point is that this treatment has to be periodical, because to reduce and maintain the intensity of infection to a low level, to protect the infected at-risk populations from morbidity, periodical treatment will be required. And the very important point about this is this treatment has to be integrated. So it can be integrated in multiple ways, either with child health days or vitamin E supplementation for preschool children, or even HPV programs for vaccination programs for adolescent girls, or even the school health programs. Now, WHO added the control of morbidity due to strongyloides as an objective for 2030 because of pre-qualified ivermectin being available at an affordable cost. The WHO has been able to add this objective. So distribution of ivermectin can be organized through the platforms used to control the other soil-transmitted helminthiasis. Pilot interventions are in place. So the WHO strategy for control, if you see in 2021, 62% of all children at risk, about 500 million children were treated with anti-helminthic medicines. Even the 99 million women of reproductive age group were treated. And we have seen some progress in the last decade by reducing the DALIs by more than 50% in between 2010 and 2019. So treatment is very, very simple. Albendazole and mebendazole, 400 milligrams and 500 milligrams respectively, effective, inexpensive, and easy to administer by non-medicinal personnel such as teachers. These are drugs which have extensive safety testing, have been used in millions of people with few and minor side effects. They are donated to national ministries of health through WHO and all endemic countries to treat children of school age. Generic ivermectin has been available at an affordable price since 2021. So this is what I have mentioned, that for Ascaris, Trichuris, and hookworm, the drug of choice is essentially albendazole or mebendazole. Ivermectin is an alternative drug, and for strongyloides, the drug of choice is ivermectin. So usually these drugs should not be given to in the first trimester of pregnancy, lactating women, or in infants. I think that is something to keep in mind. So the WHO response, there are 6 WHO 2030 global targets for soil transmitted helminthiasis, and that really is just a summary of what we have discussed. Achieve and maintain elimination of soil transmitted helminths morbidity in preschool and school age children, reduce the number of tablets required, increase domestic financial support, establish an effective STH control program in adolescent, pregnant, and lactating women, establish effective strongyloides control program in school age children, universal access to at least basics sanitation and hygiene by 2030 in STH endemic areas. So I'll just in 3-4 minutes just summarize this what I have spoken about. So just remember that the fecal-oral transmission is for Trichuris, which is a whipworm which remains in the gut. There is no tissue migratory stage, and you can see that here. I think the next presentation will be dedicated to the diagnostics. Ascaris lumbricoides, the roundworm, there is an initial migratory larval phase from the gut to the lungs. The adult remains in the gut, and you can see the egg of Ascaris lumbricoides. And fecocutaneous transmission is for the hookworms, and that is the egg scene. And strongyloides, we have already discussed. And this is larva currents, and that has to be differentiated from a very slowly progressive rash of cutaneous larva migrants. So, which is, okay. So I think, yeah, we've discussed most of this. So Loeffler syndrome is one particular syndrome, clinical syndrome we need to remember, where because it's predominantly described for the roundworm or Ascaris, and lesser for the other pathogens. So basically, because of the larval migration through the lungs, these patients will present with wheezing, cough, fever, sometimes hemoptysis and dyspnea, and peripheral eosinophilia. They will have transient pulmonary infiltrates, which can be seen in this diagram. Yeah, so this is one point, which is just a question which was in this presentation. So remember that for strongyloides hyperinfection, HTLV1 infection is a major risk factor. So HTLV1 co-infection it predisposes to strongyloides hyperinfection. And if you see, this is a patient who's on peritoneal dialysis, culture negative peritonitis, and dialysate contains 70% eosinophils. And microscopic examination of the dialysate is showing the filariform larva of strongyloides. This is another thing, just another question which was asked, where 33-year-old woman who has come in from the Dominican Republic with this Ascaris worm. So most common outcome will actually be asymptomatic carriage. So this is Ascaris, male on the left, female on the right. Hookworm egg, again, this will be discussed. This is the gross morphology of the whipworm. You can see the large whip. It resides predominantly in the cecum and colon. And on microscopy, just remember TT. Trichuris looks like a tea tray. This is the differentiating points between the rhabdiform and filariform larvae of strongyloides. So the filariform is the infective stage, and you can see in the rhabdiform larva, you have a short buccal cavity, rhabditoid esophagus, and a genital primordium. So for strongyloides larvae, the multiple stool examinations are required for asymptomatic strongyloides detection, and you can culture it on an E. coli lawn. That is one way. You can also do a string test. In some cases, it has been detected only after endoscopy and biopsy. So detection of strongyloides, especially asymptomatic strongyloides, is not very simple. Thank you for your patient listening.
Thank you, Dr. Ramesh, for your great lecture. And really, it was very informative and very clear and concise. I have great pleasure now to invite Dr. Vinay Khanna, who will be speaking on an update of diagnosis of soil transmitted helminths. I don't think that now we need any introduction. It's already greatly introduced. But I must tell something about Dr. Khanna. He is an associate professor in charge of parasitology division, Department of Microbiology, Kasturba Medical College, Manipal. He has numerous publications and again, many presentations. He has 12 years of experience on research in medical parasitology, which is very important. He has written chapters in various books on parasitology or protozoa, and he has been organizing secretary for national level parasitology workshop for last 5 years in Kasturba Medical College in Manipal. And it is really a great pleasure to invite Dr. Khanna to start his lecture. Thank you.
Thank you so much, sir. Are you able to hear me?
Yeah. Go ahead.
Thank you so much, sir. I have seen you in BHU conference, okay, with Dr. Sarban Singh. So I know you personally. I don't know whether you are able to remember me or not.
Thank you.
Good to see you, sir, after a long time. Okay, sir. So can I start my presentation? Are you able to see my screen?
No,
not
we are
yet.
not.
Pardon?
We are not able to see your screen, sir.
Not yet. We cannot see.
1 minute.
Yeah.
Yes, sir. Now it's visible.
Is it visible?
Yeah.
Are you able to see, sir?
No, it disappeared again.
1 minute, sir.
Playing hide and seek.
Hide and seek. It is playing hide and seek. Just a second.
Yeah. Perfect.
Okay. So, good evening, everyone. This is the last presentation, and I will try to shorten the presentation as I was trying to encroach Dr. Venkat Ramesh overview of soil transmitted helminths. So I'll remove that overview and directly come to the diagnostic part. What are soil transmitted helminths? These are the groups of parasitic nematodal worms causing human infections through contact with the parasitic eggs or larvae that thrive in the warm and moist soil of the tropical and subtropical countries. So Dr. Venkat Ramesh was telling that three major are there, like ascaris, trichuris, and hookworm. But I have seen strongyloides, enterobius, toxocara catis also, okay, in as important cause of STH. There are certain, local parasites also, which are of importance, like Ankylosoma brasiliensis, Ankylosoma caninum, and Ankylosoma selanicum. Apart from this, and if you see, these are the parasites which occur like in one human being. These parasites are basically common. I have seen, in single individual, especially children, having multiple parasitic infections. So that's why these parasites are considered together. So here is a case report of a 3-year-old child who's a resident of Uttar Kannada district, was referred from the local practitioner to the Kasturba hospital with the evaluation of loose stool, vomiting, and fever. The child had presented with 4 episodes of dark green colored loose stools, 5 episodes of non-bilious vomiting, and moderate grade fever. Clinical examination showed pallor, which was a significant finding, with hemoglobin level of 10.2 and CRP was 33.9. So in view of raised CRP, the child was started on IV ampicillin and gentamicin, but the symptoms were persisted. Then his ultrasonography was done, which showed hypoechoic tubular structure with well-defined echogenic walls in the hypochondrial, left lumbar, left iliac fossa region, so which was suggestive to be a worm. So microbiological evaluation was done, workup was done, and on wet mount preparation, we have seen stool WBCs, but there were no RBCs. Multiple morphological forms of parasites were seen. As you can see in this picture, the green arrow shows Trichuris trichura. The orange arrow is showing echinostoma. I have published this case report. And there are, and then this blue color arrow is showing unfertilized egg of Ascaris lumbricoides. And parents also noticed passage of worm in the stool in this child, and they also found the worm in the patient pants too. The child was anemic. You know that leading cause of anemia in children is basically hookworm. Hookworm means Nigator americanus and Ankylosoma duodenale. Whipworm infections like Trichuris trichura can also cause significant blood loss. There were some studies which were done previously and which has showed that with the help of tagged RBCs, as much as 8.6 ml of the blood can be lost in a day in a severely or heavily affected child. So here you can see the Echinostoma species, which are not routinely encountered in the laboratory, and they may go unnoticed. So, and these eggs of Echinostomas are basically closely resemble that of egg of Fissiola hepatica and Phaeolopsis busci in shape, but they are smaller in size, right? So the child was started on tablet albendazole, followed by 2 days of IV parental pymioid, and then mebendazole was given once a week. The child responded well with the above measure and remained asymptomatic after 3 days. Okay. So what is the take-home message for this case report? Multiple form of soil transmitted helminth can occur in a single patient, especially children. And parasitic infections are usually highly contagious. So if one member of the family is acquiring the worm, the rest of the family is at risk. So in that case, a deworming of the entire family is must. Okay. And chronic infestation have been linked with the delayed physical and cognitive development in the children. So clinician should focus on his cognitive development, and they should take his weight according to the age. So now coming to the diagnosis. Okay. So these are the helminths which are usually asymptomatic, okay, or the mild symptoms may be present. The patient usually tend to ignore these symptoms. So the clinician should have a high clinical suspicion to know the local epidemiology, the state or the country of origin of the patient, okay, and then he should request the fecal examination if he's thinking that, okay, the patient might be suffering from these infections. And if it is a light infection, in that case, concentration techniques can be used, like formalin, ethyl acetate sedimentation technique can also be used. And there are certain other techniques like Catocat's method, thick fecal thick smear method can be used. McMaster method can also be used to know the intensity of the disease. Ultrasonography, endoscopy are also important diagnostic techniques. Okay, so which can help us in knowing the complications. For example, in case of Ascaris, intestinal obstruction can happen, or pancreatic involvement can happen. In that case, diagnostic imaging techniques such as ultrasonography or endoscopy will be quite useful. So here is a patient presented with a hookworm infestation. Usually the symptoms start with the ground itch, which is the first sign of infection, with the severe itching at the site. And basically when skin touches the contaminated soil or a sand, the larva penetrate the skin. So the larva basically penetrate the skin with the help of certain, proteolytic enzymes which it is releasing, which are basically and the symptoms I told you may be there or may not be there. But ground itch is the first important symptom in case of cutaneous hookworm infection. So if you can identify which worm I'm showing here, you can see the X. Okay, Dr. Venkat Ramesh has already shown the X, right? So you can know that what I'm talking about. I'm talking about hookworm. Okay, so if you see the adult on left side of the picture, you can see 2 pairs of big teeth. Okay, in total there are around 6 teeth which are seen in Ankylosoma duodenale, and on the right side you can see egg of hookworm. Right. So these are the left side of the picture is Necator americanus, and the right side is Ankylosoma duodenale with 3 pair of teeth. So what is the difference? The Necator americanus have a small buccal capsule and with a pair of semi-lunar type of cutting plates. Okay, as compared to that of hookworm, which is having 3 pair or 6 teeth. Right. So this is a basically endoscopic picture of the endoscopic video, you can say, of the worm. These hookworms basically suck the blood from the intestinal vessel. How they suck the blood? They get attached to the intestinal wall by either buccal capsule or by the teeth, and then they start releasing or secreting hydrolytic enzymes. Along with that, anticoagulants are also released. So that's why there is a lot of ingestion of extravasated blood by these worms. You can see it appears as a pink color worm, right? Okay, so on the basis of X, we cannot differentiate between Necator americanus and Ankylosoma duodenale. And you can see the egg with the larva which is moving inside in this picture. I hope you are able to see. Okay. So the differentiating feature between these two is basically the cutting plates in case of Necator and teeth in case of Ankylosoma duodenale, right? Okay. So here is the egg under the microscope. I am trying to focus under the microscope. So the eggs are basically around 60 to 70 to 40 to 45 micrometer in size. They are non-bile stained and they are surrounded by a thin, highly translucent eggshell. And I am measuring the size of the egg with the help of my software. And here you can see 4 to 32 blastomere that will ultimately transform into the larva. And you can see clear space between the eggshell and the blastomeres. On the basis of X, I already told you cannot differentiate between the species. So for that reason, you need to do the coproculture for the stool specimen to differentiate between the species. So basically here the scientific sample of the culture should be incubated and examined for the larva after 2 to 3 days under the microscope. Okay. So as Dr. Venkat has also shown you the cutaneous larva migrant. Here is another picture with the histology of the larvae here. So you can see the serpiginous tract that are formed due to migration of the larva under the skin. It is mainly caused by these cutaneous larva migrants are mainly caused by animal species such as Ankylostomma brasiliensis, Ankylostomma selanicum, okay, or Ankylostomma caninum. So in this picture, if you see the black arrow, okay, so this is having a double lateral LA, okay, which is a classical of the larvae, and they lack the reproductive structure, which indicate the immature stage of the larvae. The size of the larvae is around 15 to 20 micrometer in case of Ankylostomma, and it is little larger in case of Nicata. And if you take the skin biopsy, most of the time you may miss the larvae. Why you miss the larvae? Because these larvae precedes the inflammatory response which is seen in the patients. Okay, so the inflammatory response will come, and by the time you see the serpiginous tract and you try to take the biopsy from those lesions, the larva will be gone out of that area. Okay, that's why these larvae are hard to find after skin biopsy. You will see only the inflammatory tracts or creeping eruptions, right? Oh, this is another video which we have taken where you can see the ulcer on the foot with a serpiginous tract on the foot of the patient, right? And if the patient is suffering from enteritis or some diarrhea, then stool microscopy may also show the typical hookworm eggs. But in case of cutaneous larva migrants, the eggs are not shed in the stool. Okay. Right. So here you can see the eggs and how to observe under the microscope. You have to examine the slide in a zigzag manner under low power. And if you see something suspicious, then look at high power. So what are the other diagnostic methods other than the microscopy? We can do immunodiagnostic techniques such as Western blot or ELISA test. ELISA basically uses secretory antigens from the Ankylostomma caninum, okay, which is commercially available for detection of IgG or Ig in the serum. Western blot test can also be done to identify IgG4 antibodies to certain proteins which has been extracted from Ankylostomma caninum. They are quite sensitive and specific tests, right? So molecular tests can be done, but they are mainly used in the research setting, and they can also be used to differentiate between Necator americanus, Ankylostomma duodenale, or Selanicum or caninum. Okay. And one more important thing for the diagnosis, sometimes you can see the mite eggs in the stool, right? So you need to find out whether it's really an artifact or the egg. You can do the culture. If it is the egg, the larva will hatch, right? Or other thing, you can look for the size. The mite eggs are usually larger as compared to that of hookworm. The second thing, the blastomeres might not be present, and sometimes you can see the mite legs, okay, in the wet mount, right? Okay, so if I told you, if the if the infection is light, then in that case, stool concentration methods such as flotation method or sedimentation method can be used. Okay, then once you have done that, you can do in vitro cultivation for species identification. Second important thing, you have to look for the eosinophil count in the blood, as a number of patients will have higher eosinophil count. In fact, I have seen that if even the clinicians are not suspecting the parasite, if eosinophil count is high, I try to do the concentration method, and most of the time I am able to identify a different parasite, because the infection is light, but the blood sample itself will give you an indication that eosinophil count is high and the patient might be having some parasitic infection, right? So other way of diagnosing these parasites or the hookworms by Hardamori filter paper tube method, Petri dish slant culture method, agar plate method, which is quite sensitive, modified stool techniques for egg counting. Okay, if a clinician asks for like how much more day I have to give the albendazole or ivermectin, in that case they sometime, very rarely, they may ask for what is the egg count in the sample. So in those cases we do the stools technique, right? So who is next in the race? You can see a lot of larvas moving around. Okay, so I'll give you a hint. These larvas, if you demonstrate in the microscopy, they will give you a definitive diagnosis. So if any answer, I'll be very happy. This is basically Strongyloides cercoralis. So it is also called as military worm. It was first found by Louis Normand in 1876 in the feces of French soldier, and it is mainly present in hot and humid climate, commonly found in immunocompromised and HIV patients. Adult worms resides in the duodenum, jejunum, and they are also free living in the environment. Here you can see a female adult worm filled with the eggs. Okay, this is from my lab. You can see the adult worm, female adult worm, which is filled with the eggs. Eggs are basically, if you see anterior, they are arranged anterior posteriorly in a row of 10 to 20 eggs. So okay, these female worms are seen in human intestine. Male worms are rarely encountered. I have never seen. I have seen only female worms. And the size, if you try to measure it, is around 2 to 3 millimeter long by 30 to 50 micrometer broad. And the free living male worms are slightly smaller, right? Okay, so here you can see the female adult worm with the eggs. So the sensitivity, if you do the microscopy, as such sensitivity of microscopy is low, especially in patients who are asymptomatic or having a mild symptoms. Okay, because these larvae are intermittently excreted from the feces. So that's why we always tell the clinician to send us the multiple stool samples over several days, or maybe alternate day for the next 6 days. If they can send, that would be wonderful. So this is another picture of egg of Strongyloides. It is fulborni. From this Strongyloides fulborni eggs are basically, these Strongyloides infect the primates. They're normally not present in the humans. And one important thing, if you notice, the egg is having a larva inside. So eggs are also called as ovoviviparous. Okay, these larvae are immediately hatching from the egg. That's why you only see the larva in the stool sample. So basically, there are two types of larval forms, as Dr. Venkat was telling: repetiform larvae and filariform larvae. So filariform larvae are infective forms, and repetiforms are present in the stool normally. And if you try to differentiate between them, you can see on the left side of the image, you can see a notched tail. This notched tail is basically present in the filariform, and pointed tail is seen on repetiform form of the strongyloides, right? This is a microscopy which I have done, and I try to focus on the notched tail. Okay, so there are many stages of the larva, means from L1 to L4. So L1 stage is basically called as repetiform stage, while L3 is called as filariform stage. So this is another picture of the same. Okay, it is very important to differentiate between hookworm and strongyloides larva. Okay, because the treatment is totally different. One is one patient who is having a strongyloides will get ivermectin. The patient who is having hookworm will get the albendazole, right? And you know that strongyloides tend to cause hyperinfection and disseminated strongyloidiasis. So you have to be very careful if you are only finding the strongyloides in the stool sample. So it is quite important. If you see the larva itself, then it is important to differentiate between these two. So if you see the buccal cavity is shorter in case of strongyloides, but it's longer in case of hookworm. And if you see the esophagus will be longer in case of strongyloides, but it is shorter in case of hookworm. And coming to the tail part, I have already told you the filariform larvae of strongyloides having a notched tail, while repetiform larvae having a pointed tail. But the tail will be pointed both in filariform as well as repetiform larvae in case of hookworm, right? Okay, so this I'm showing a different picture of larva currents. Dr. Venkat has shown a different picture. Anyways, it is good for learning. So here you can see articular rash can occur due to larval migration. Movement of the larva in the skin is faster as compared to the hookworm larva. In the books, it is written that the larva move as fast as 10 centimeter per hour. Okay, and this condition is called as larva currents, and the rashes are intensely itchy in this condition. So here is another patient who was basically 47-year old, who was taking steroids for dermatomyositis, and he presented with hemoptysis, rashes, abdominal pain, and melena. And he was found to have a strongyloides cercoralis hyperinfection syndrome. So this hyperinfection syndrome, whenever it is present, you should consider it as a potential medical emergency. It requires a prompt therapy, and if any delay in the treatment, definitely it will lead to the fatal outcome. And in these cases, ivermectin has to be given at least for minimum 2 weeks, right? And if clinician is suspecting hyper infection syndrome, then large number of larvae will be seen in the stool, and sometimes the larvae are also present in the sputum of the patient, right? Okay, so here you can see a case of disseminated strongyloidiasis. This is adult female worm along with the eosinophilic infiltration. Okay, you can see the eosinophils basically in the intestines. So what happened? So whenever these larvae invade the GI tract, okay, so they may migrate to various other organs such as CNS, or maybe liver, or kidney, or the peritoneum. Along with them, enteric flora can also move. Okay, so this disrupted mucosa along with the enteric flora can lead to gram-negative septicemia. They may lead to pneumonia, or they may lead to meningitis. So I was telling you that agar plate culture method is quite an important test for them for the diagnosis. And also to differentiate between hookworm and strongyloides. So the principle is basically this: the larva will migrate from sample of the stool and covered by the bacteria. When the larva migrate through the agar, it leaves a trail of the bacteria that can be observed with time. a fresh stool sample is required. You should always send a fresh stool sample. This is my request to the clinicians. And you should reject the sample if it is refrigerated and if the time has been crossed more than 12 hours, because the larva anyways will be dead in that case. Okay, we cannot do the agar culture plate method in those cases, right? So you should assume that the larva, you should assume that the sample contains the filariform larva, because you know that filariform is an infective stage. So they may penetrate the skin and may cause the infection. And we should also warn our co-workers for the work, for the nature of the work, what we are doing. Okay. So this is a nutrient agar plate from the patient. Basically will be used for the patient for agar plate method. And we can add around 2 to 3 grams of unpreserved feces in the center of the agar plate. And then we have to seal the plate by placing a tape around the circumference of the plate, right? We don't want any escapees. So let the sample incubate for 2 to 3 days and then examine the agar surface for larva. And then bacterial colony trails has to be seen. Speciation can be confirmed by obtaining a migrating larva, okay, and examined under the microscope. So these plate has to be examined up to 6 days, okay, and the reports will be bacterial trails on the agar, indicate the presence of Strongyloides stercoralis, and look for the adult worms, larvae, and eggs in the plate. Okay. So here you can see the plate. The lot of larvae are moving around. And this whitish structure you can see is basically bacterial colonies, right? Okay. Okay. So what are the other diagnostic methods other than the microscopy, other than the culture? So there are certain immunodiagnostic techniques such as ELISA can be done, or antigen detection can be done. But the only problem with these techniques is the cross-reactivity. They can cross-react with the filarial worms, okay. And the other thing, the antibody may not be generated properly in case of HIV or HTLV infection. So in those cases you have to be very cautious, basing your reports only on the immunodiagnostic techniques. Okay, regarding molecular techniques, they are the better, they're important tests. But the only and they are also good prognostic marker to monitor the therapy. These molecular tests can become negative after a successful therapy. Okay, if you wanted to know the course of the patient with a hyperinfection or the disseminated strongyloidosis, so in that case molecular testing can be done, and these tests will become negative after the patient with a successful treatment. Okay. The other important thing is the artifact. Sometimes the plant hairs may be mistaken for the hookworm or the Strongyloides larva. Often, if you see, the plants are basically, hairs will be broken at one end and have a retractile type of a center, and they lack any stricture or internal structures like esophagus or genital primordium, etc. So you have to be very careful, because I have seen some of the newer PGs, they misdiagnose these plant hairs as larvae. Okay, this is another case. A 3-year-old child presented with the colicky pain. The child was not passing stools for 2-3 days, and previous history suggestive of passing worms by the mouth. Clinically, he was toxic looking, dehydrated with marked abdominal distension. The physical examination of the abdomen show guarding and rigidity, and blood tests show high neutrophilic count. And this was the X-ray which was showing distension of the small and the large bowel with the air fluid level. Okay, so with the acute abdomen, the patient was taken to the OT, and enterotomy was done. So here you can see extracted ascaris by mean of enterotomy. So post-operative period, the child looks normal. Okay. So how to diagnose ascaris? So you can diagnose by characteristics X. You can do concentration techniques. Sedimentation method is more preferred over the flotation methods. Adult worms can be seen during colonoscopy or barium X-ray, as you have seen in our case. Larva can be seen in the sputum in very severe cases. And here you can see the colonoscopy picture of a roundworm in the intestines. So this is a preserved specimen in our lab, where you can see the cut portion of the intestine with the numerous roundworms. Okay, these are the male and female worms. The male worms, if you see, the posterior end is curved. Okay, and they have scules also. But female, the posterior end will be the straight and pointed. And if you see the eggs, there are two types of eggs: fertilized and unfertilized eggs. Sometimes these fertilized eggs may lose the mammillation, okay, thick albuminous coat. So these types of eggs are called as decorticated eggs. So these are the few important points about the fertilized eggs. The size is around 45 to 70. They are round to ovoid, brown to yellow in color, and they have a crescentic shape, which is created by a single cell separated from shell at both the ends, and they have a mammillated outer coat and shell cover. They get embryonated in around 2 weeks, and they are highly resistant to disinfection. Okay, you should be aware of that point. Then we have unfertilized eggs, which are quite larger, around 85 to 95 micrometer. They are elongated, occasionally irregular, and sometimes I have seen bizarre forms also. And shells are often very thin. They are brown in color, and internal material is mass of irregular globules and granules that fills the shell. So in many cases, I've seen that mammillated covering is attenuated or absent. So unfertilized eggs, these unfertilized eggs are not infective. They may easily disintegrate. That's very important. And you cannot differentiate between eggs of Ascaris lumbricoides and Ascaris suum. Suum is from the pigs. Okay. So if you want to differentiate, you can differentiate using molecular methods. And there are certain other important technique called as Cato-Katz technique, which is adopted by WHO, and it was developed by Dr. Can Cato and modified by Dr. Katz. So it is a gold standard technique for identifying multiple helminthic infection. It is also used as a egg counting techniques. So okay, so I was telling you, if you want to differentiate between Ascaris suum and Ascaris lumbricoides, you can use immunodiagnostic techniques, but the problem is of low cross reactivity with Trichuris suis. The cross reactivity is there, but it is low. Okay, that is the only problem. But if you go for the molecular techniques, mainly mitochondrial genome based test, okay, they are used. They may differentiate between Ascaris lumbricoides and Ascaris suum, but the differentiation is very minimum. It is only 1.9%. Okay, so these are the techniques which are still developing. Okay, and this is another case of a 68-year-old man underwent a routine colonoscopy. He had no complaint of illness, but had recently traveled history to the endemic area. The worm-like object was of around 30 millimeter in length was observed and recovered. So this is the worm, and I hope you know the diagnosis. This is a case of Trichura infection. So it is also called as whipworm because the adult worm resembles the handle of a whip. It mainly affects the children. Eggs are barrel shaped. Okay. Human infections are mainly because of Trichura, but rarely Trichuris suis, which is also called as pig whipworm, or Trichuris vulpes, which is also called as dog whipworm, can also be seen in human. I have read a few of the case reports for the same. Okay. So adult worms, they are whip shaped anterior end is thin or hair-like, and the posterior end is short and thick. The male are little whitish, around 30 to 45 millimeter long, and they have a coiled posterior end. Female are longer, and the posterior end is either comma or arc shape. Right. So this is also a specimen from my lab where you can see the Trichuris trichura whipworm. Okay, here you can see the female worm with a comma shape posterior end. Okay, and thin anterior hair-like structure, which is a anterior end. Right. So these are barrel-shaped eggs which are elongated, around 50 to 55 micrometer in size, and they have polar plugs at each end. These plugs are colorless. See, why I am focusing on the polar plugs, I'll just tell you little here. If you see, okay, this is Trichuris trichura by UV microscopy. I'm not interested in this. I'm interested in this picture. There are certain atypical eggs of Trichuris trichura. Okay, here you can see atypical type of, but they are Trichuris trichura, but sometime in microscopy they may appear after the treatment. Okay, even if the patient has taken the treatment and the severe infection was there, then the eggs may become abnormal. There are certain other eggs which mimics that of Trichuris, which are called as anatrichosoma eggs. Here you can see anatrichosoma eggs, right? So this is tissue dwelling nematodes, okay, that rarely infect the humans. They are basically associated with wild primates or rodents. So they show polar plugs, as you can see with the arrows. Okay, here you can see the arrow. They have a polar plugs, but their shell is striated, and you can see the coiled larva inside. And if you see this picture, this is called as Capillaria philippensis. The eggs are around smaller as compared to Trichuris trichura. The size is around I think 35 to 45 micrometer, and the width is around 20 to 25 micrometer. Okay, but they have the plugs. But if you see the polar prominences, they are flattened. Okay, polar prominences are flattened, and they also have a striated shell. Okay, eggs are basically unmembranated once passed in the feces. And here are the different sizes of the eggs. And if you see the left side of the egg, this is egg of a Trichuris vulpis, and this is the right side egg is a Trichuris trichura, right? So this is a picture of a child with a rectal prolapse, and you can see rectal prolapse is one of the important complication of trichuriasis, and you can see a lot of worms on the rectum, right? So characteristic barrel-shaped eggs, eosinophil counts, increase IgE level, and colonoscopic finding will confirm the diagnosis of Trichuris trichura. And this is a colonoscopic video of a child where you can see a lot of one worm which is attached to the intestinal mucosa. The anterior end is attached and the posterior end is free, right? So Capillaria philippensis, I have already told you, they are similar to that of Trichuris trichura. They reside in the small intestine, but they are basically occur after ingestion of the freshwater fish, which can lead to diarrhea and emaciation. Prolonged treatment with albendazole up to 2 weeks is required to treat Capillaria infection. So here you can see the picture of Capillaria. It is peanut shaped, striated thick shell, and mucous plugs are present, but they are flat, right? Okay. Can you diagnose this? If anybody can diagnose this, I'll be very happy. Any guesses? You can write in comment box. So here is the colonoscopic picture of the same. You can see the worm moving around in the intestines. Okay. I think this will solve your problem. You can see the eggs. The egg has a one flattened end, another end is a convex. So it is a case of pinworm. Pinworm. Here, basically, I'm trying to focus the pinworm for the participants, and then we have made the video. And if you see the anterior part, okay, if you see the anterior end of the pinworm, it has a cephalic extension. And if you see the middle part, you can see the esophagus. Okay, double valve esophagus, right? So this is also a worm, female worm, which is filled with the eggs. So there are a lot of eggs inside the worm. I'll show you 1 minute. I'm trying to focus here. Just a second. Here you can see the eggs. Yeah. Can you see the worm with lots of eggs inside? Okay. So what is the characteristic feature of the egg? It is colorless, around 50 to 60 micrometer. It's embryonated and it contains a tadpole larva. Okay, the eggshell is smooth and one end is flattened, another is convex, right? So the patient will present with the perianal itching. For that reason, direct identification methods are also there, like NIH swab. Okay, so this NIH method was basically devised by National Institute of Health, US. What happened here? A glass rod is taken, okay, which is attached to the cellophane tape by a rubber band, right? The cellophane tape is rolled over the perianal region to collect the sample. An early morning sample before the patient, goes to the bathroom or use the toilet is very optimal. Okay, you should tell the patient he should not go to the toilet or should not take the before issuing a negative report. So that is according to the CDC guidelines. So at least 6 successive days of sampling has to be done in suspected cases, right? So the another method is called as cellophane tape method. So here clear cellulose tape preparation is used, and it is quite a widely used procedure. Okay, for pinworm infection, Enterobius vermicularis. The eggs are usually not seen, okay, but you can see the worms. Okay. Okay, another case, a 26-year-old college student has taken the homeopathic treatment for parasites after experiencing recent passage of whitish segment of the worm. But the passage of the worm continued, for which she has consulted the hospital. A stool specimen was collected and sent for evaluation. So here is the picture. You can see examination showed 2 objects of interest at 400 magnification, and parasitic eggs measuring around 30 micrometer in diameter on an average was seen. So it's a case of teniasis, okay, mainly caused by Tinea saginita. Why I'm saying saginita? A proglottid. This is a proglottid, okay, which is basically injected with the ink, and we can see the branches, uterine branches. Okay, so in Tinea saginita, there are typically around 15 to 20 uterine branches which are seen. But in case of Tinea solium, around 7 to 13 branches are seen. So it is important to differentiate between Tinea solium and saginita, because you know that Tinea solium is known to cause neurocystic sarcosis. Okay, it is important to differentiate between these two, and you can differentiate only on the basis of proglottids, not on the basis of eggs. Eggs look similar in both the cases, right? So here are the eggs, and they are around 30 to 40 micrometer in size. They are round and they are covered by 2 layers, and they have striations. Okay. And if you come to the adult worm, okay, the size, if you see, the size of the worm is less than 5 meter in case of Tinea saginita. In case of solium, it is around 2 to 7 meter in length. And if you see the scolex, the head part, the one species has the hooks, and that is Tinea solium. But Tinea saginita doesn't have any hooks. But suckers will be present in both the species of Tinea, right?
Dr. Khanna,
And
we have to
here
wind
is-
up.
Here is the patient. Here is the patient. You can see the proglotid, which is crawling out, and it can cause certain non-specific symptoms, irritation, abdominal pain, and sometimes change in appetite of the patient. Right. So here you can see a cysticercus larva, which is very important. So here demonstration of invaginated squales with a hooklet is seen, okay, which is diagnostic of cysticerci. Cyst can be seen in various stages of degeneration. They can produce lot of inflammation if they are in unviable stage, right? So these are the cysticercus cellulose which are surgically removed. There are different type of cysts. Here you can see subcutaneous cysts, which are basically asymptomatic, but can be can manifest as palpable nodules. Then there are certain muscular cysts, cysticercosis, which can cause muscular pain, weakness, pseudo hypertrophy, and sometimes there is involvement of the eye also, okay, or conjunctiva or lids or sclera. 1 week back only we have diagnosed cysticercosis as a breast lump. One breast lump case has come, so it was found to be cysticercus. Then there are certain cysts which are basically larger cysts. They are called as racemose cysts. Okay, they form clusters and they measure around 10 centimeter in diameter, right? So this is important. This is basically CT scan or X-ray or MRI picture. It is important techniques, okay, imaging techniques, because they form a major criteria for diagnosing NCC. Okay, so if you see hole in the dot, okay, hole in the dot with the dot, okay, hole with the dot is diagnostic of CT scan. Okay, and if you can do the surgical biopsy, if you are able to demonstrate the cyst with the skull legs, that will also be a major criteria. And if you do the fundoscopic examination, if you can see subretinal cyst, that also comes as a major criteria for NCC. So there are certain minor criteria also for diagnosing NCC. So these minor criteria, maybe the antigen is positive or antibodies are positive, or clinically there are manifestation of subcutaneous cysticercosis, okay, or there may be certain non-specific features like patient had seizures or blurred vision and all. So those comes in minor criteria. So to come to the definitive diagnosis of NCC, at least one major and two minor criteria should be followed, right? So other than microscopy and microscopic detection, biopsy or histopathology detection, antigen and antibodies also play very, very important role, and they have a higher sensitivity and specificity, and there are no cross reaction with the other intestinal helminthic infections. Okay. Other than that, LAMP assay, I wanted to highlight on the LAMP assay, which are quite useful and increasingly
Dr.
useful
Khanna, I have
nowadays.
to interject.
Okay.
We have way overpassed the allotted time, so kindly conclude.
Yes, sir. Just finishing, sir. Okay. So they are highly sensitive and specific tests for diagnosis. So finally, my talk has come to the end. Thank you for patient listening. Thank you.
Thank you, Dr. Khanna, for a great talk. In fact, we would have loved to go on and on. Very interesting. The videos were really great. So I really congratulate you on this. Unfortunately, we have a limitation of the time. So I have to tell you to stop. Thank you very much.
No problem, sir.
Over to
Thank you so
Kavita.
much.
You are muted, Kavita.
Thank you, sir, for moderating that session on soil transmitted helminth. And I thank all the speakers for excellent and clear presentations, and online audience for very enthusiastically participating by questions. We are thankful to all the participants. I thank my core committee members of Manipal Center for Infectious Diseases and also the core committee members of Tropical Medicine Subcommittee of Clinical Infectious Disease Society. All of you who are interested in ID, please enroll to Clinical Infectious Disease Society by logging on to our website. I request all the speakers to turn on the video once for a photo shoot. Please. All the participants as well. Whoever is present can please turn your videos on. It was very nice of you to participate. And we hope to meet all of you in person. We will end this session by playing up the video once again, so that you can look at the upcoming meeting on on the occasion of World TB Day, but we'll be doing it on 17th March. And you can give your suggestions on the topics which you would like us to conduct CNEs in future, and also the mood or the format in which you would like to listen from the experts. Thank you very much. Thanks once again. I conclude this. We'll play our video. Thank you.
Thank you. Bye-bye.
Bye-bye. Bye.